Good afternoon, good evening, or good morning, depending upon the areas of the world which you belong to. Well, I have great pleasure to welcome all of you to our webinar series of Learn from the Legends. Today we are entering the 15th episode of the uh, webinar series in which we are bringing the true legends of neonatology in front of you. Today, really, we had a great legend, that is Dr. Niranjan Thomas, who is going to speak us on the basic concepts and the cooling process of therapeutic hypothermia in resource-limited settings. I have great pleasure to welcome Dr. Niranjan Thomas to this platform. Welcome, sir. And the moderators of this session are Dr. Vishnu Bhatt, who is the head of the Department of Pediatrics and Neonatology from Jipmer, Pondicherry, and Dr. Sunil Kishore, who is the consultant neonatologist at the Medicover Hospital, Vizag. I welcome both moderators to this program. And I welcome all of the delegates from all parts of the globe to this wonderful learning experience. Thank you, and over to the moderators.
Good afternoon to one and all. It is my duty to welcome Dr. Niranjan Thomas, and I am also thankful to the organizer for inviting me to be here. I have a co-chairperson or moderator, Dr. Sunil Kishore, who is from Vizag, and I am asked to introduce the topic. See, as you know, perinatal asphyxia is a very important issue, especially in developing country like ours, where almost 30% of the mortality is neonatal mortality is related to perinatal asphyxia. And about 60% of those who had significant asphyxia will develop handicap, or they may become children with special needs. So it's an important issue. And various treatments have been tried, among which therapeutic hypothermia probably is the most important. And we have Dr. Niranjan Thomas, who will be introduced by my colleague later. But he is the one who has done this miracradle experiment, and now many centers are using this miracradle for cooling, or poor man's cooling system. Now the question comes, when to cool, whom to cool, when not to cool. That's very important. So one should know when not to cool or when to stop cooling. And if you cool everybody and in different circumstances, outcome may not be good. So many times what happens, people cool and then baby dies. After that they say, okay, this is very dangerous thing. So there is problem in selection of case and also the method of cooling. So Dr. Niranjan will discuss and he will tell us whom should be cooled and where we get the maximum benefit and how long to cool, when to rewarm, how to rewarm, and what are the complications we can develop. Many people may think, okay, whether we can cool the preterm babies, whether only term babies we cooled. So these questions also need to be answered. And in our setup, there are few referral centers, and infants have to be transferred from long distance. So many times transport is a bigger issue, whether we can cool like Western countries during transport. These are some issues which we may have to see. Another important issue may be follow-up of these babies. Unless we do long-term follow-up, what happens, what is the real outcome after 5 years, 10 years, what happens? That cannot be answered. Most of the follow-up studies be around 1.5 to 2 years, not more. So I think we need to follow them up. And I should not keep on talking, because I will reduce the time of the speaker speaking, and I hand over the stage to my colleague, Dr. Sunil Kishore, to introduce Dr. Niranjan Thomas. Dr. Sunil Kishore.
Yeah, thank you, sir. Thank you very much. So, and it's really my privilege to introduce Dr. Niranjan Thomas, sir. Sir is currently working as consultant neonatologist in John Kirner Women and Children Hospital in Melbourne, Australia, for the last 1 year. So before that, sir was working as professor and head of the department in neonatology in CMC Vellore. Sir has done his fellowship in neonatal and perinatal medicine from Sick Kids Hospital in Canada, and his medical training was from MD as well as DNP from CMC Vellore. And to his credit, Sir has 61 publications in indexed journals, and he is journal reviewer for many international journals like ADC, BMJ, and Lancet Global. So more than above all, Sir has developed Mira Cradle, which works on principles of PCM, phase changing material, which is a low-cost device for neuroprotection and therapeutic hypothermia. And it's being used in more than 100 hospitals in India as well as abroad also. And Sir has patent for Mira Cradle, and a big applause for that. Having done so much of work in therapeutic hypothermia and neuroprotection, for today's topic, I don't think anybody else can do better justice than Sir. So over to you, Sir. Before that, a small request to all the participants. So all of you, like whoever is posting queries and comments as well as any questions, please post in Q&A box, not the chat box. Please post in Q&A box so that we will be able to take up at the end of the session. Over to you, sir.
Thank you, Dr. Sunil and Dr. Vishnu Bhatt, sir, for your kind words. I've known you for many years and we have good relationships. I'll start sharing my screen now. So good evening, everyone, and greetings from Melbourne. It's only 10:45 in the night here, but I'm quite excited, even though it's nearly the middle of the night, to be part of this program. It is my pleasure and privilege to be part of this webinar series, and Manoj and his team need to be congratulated on their effort. When I heard about the IAP NeoCon being cancelled, I thought, oh, this is a COVID disaster. But it's been beautiful the way it's been adapted by the team to deliver something that's even better, a series of high quality talks that go throughout the year. I take this opportunity to thank Manoj, his team, and the IAP NeoCon for inviting me to be part of this webinar series. As many of you may be aware, I worked for more than 20 years at Christian Medical College, Vellore, and this is the centenary building where I spent nearly 2 decades of my life as a neonatologist. Before I moved to the Joan Kerner Women and Children Hospital in Melbourne a year ago. And the Joan Kerner Women's and Children Hospital is the 5th NICU that has been started in Victoria, and it opened in September 2019, and I'm happy to be part of the team that is building up this unit. Before I start, I need to make some disclosures. The disclosure is that I was involved in the development of the Mira Cradle and I hold 2 patents. But however, I do not have any financial benefits, neither from the development or from the sale of the Mira Cradle. Now, when Manoj asked me initially to give this talk on the basic concepts and with a focus on low resource settings, I was not sure because cooling has been happening for more than nearly 2 decades in high income countries, and in CMC Vellore, we have been cooling from 2007. So I'm not sure exactly what people would want or know already. So I asked a couple of my previous students who are themselves consultants now, and also asked some of my colleagues in CMC what I should focus on. So there are 6 questions that I from the feedback that I got, which are challenges for cooling babies in resource limited settings. The first question is, should you cool babies in the settings at all? Is it safe? Are we sure we should be able to cool babies in the settings? The second is, what facilities or settings should we cool in? Can we do it in every hospital, or is there a certain things that we need to have infrastructure before we can start cooling? The third is, who should you cool? Is there any differences in patient selection between high income countries and ours, and between the trials that are already conducted and what we should be doing? How should you cool? Is there any alternatives that we can use as far as equipment goes? How do you monitor and follow up these babies? We heard Dr. Vishnu Bhatt sir saying that it's so important that we have long-term follow-up. How do we monitor for complication, and how do you follow up these babies? And the sixth question is, do you need amplitude integrated EEG and MRI as a must before you start cooling? So the first question, should we cool babies? When we talk about any intervention, there are three things that needs to be answered: safety, feasibility, and efficacy. Any intervention needs to be safe, it should be feasible in your setting, and it should demonstrate that the benefit outweighs the harm in terms of efficacy. So can we have the first poll? Do you believe that there is enough evidence on safety, feasibility, and efficacy in cooling in mid-income countries, low mid-income countries like India? So we have 66 persons, about 2/3 of them, who believe there is enough evidence on safety, feasibility, and efficacy to cool babies in low mid-income countries like India. And about 1/3 says there is not enough evidence. That's good to know. So let's see what. So if you look at the evidence, this is a Cochrane review, that a meta-analysis that has 8 trials, a total of 1,334 newborns. What it showed was that therapeutic hypothermia reduced the risk of death and major disability with a relative risk of 0.75. So there's about 25% reduction in death or disability, and the number needed to treat was 7. And not only did it decrease death and disability, it also increased the rate of survival of those survivors with normal neurological function at 18 months. Now, if you look at common interventions in neonatology, a number needed to treat of 7 is very good. For example, much better than even surfactant therapy. The problem is that all these trials were done in high-income countries, so we cannot really postulate whether can we use this evidence and say that we can cool in low mid-income countries like India? Well, we could, because if you look at surfactant therapy, nobody really studied it in other countries. They just adapted it to low and middle income countries. Now, there are some arguments against cooling in low and middle income countries like India. The first thing is, people feel that it's unsafe, mainly because of the fact that there is unregulated practice and the quality of intensive care is not always the same everywhere. And more importantly, there is a feeling that it might not be as effective as in high-income countries. The biological plausibility put forth is that there is more infection in India. So when you have infection, there is what is called the double hit theory. So in the background of chorioamnionitis, the brain is already injured, as you all know, because of cytokines. And on top of that, you have a double hit with asphyxia. The theory is that cooling will not be beneficial. The second biological plausibility theory that has been put forward is the fact that many of the babies in countries like India are small for gestational age and already have chronic hypoxia with established brain injury. And we know that cooling helps only in the first 6 hours, in the latent period. So it may not really help in these babies. In addition to this, there are factors like lack of infrastructures, many home deliveries, poor transport, that's already been mentioned by Dr. Vishnu Bhatt. So babies come very late present very late with brain injury. In addition, there is poor cooling practices, the so-called poor cooling practices, I would say, using low-tech methods, cooling babies with mild encephalopathy, and a lack of sedation. So these are the theories, or these are the points that have been put forward by people who believe that cooling should not be done in low and middle income countries or in low resource settings like India. Now let's look at the safety. So I said we need to demonstrate safety, feasibility, and efficacy. So looking at safety and feasibility, this is a table that shows the Indian studies that have been done so far, looking at safety and feasibility. So we have studies from Vellore, Pondicherry, Calicut, Manipal, St. John's, Bangalore, and also 2 multicentric trials that have looked at cooling babies in India. The total number of babies that have been cooled so far, if I count all these studies, is about 654 babies. The study, the Thecotherm Helix study, that is a multicentric trial that took place in centers in Chennai, Pondicherry, Bangalore, Mumbai, and Calicut, showed that there was a 50% of the babies actually had gastric bleeds, and there was a 20% mortality, which is acceptable. And these babies are all babies who are sick with moderate to severe encephalopathy. All the trials, all of them reported that it was safe and feasible. In 2013, Pollia and et al. Published a meta-analysis in PLOS One journal. They looked at all the RCTs that had been done in low and middle income countries, and they looked at mortality, and they found that even though there was a trend towards a reduced mortality, 0.74 relative risk, it was not statistically significant. So the conclusion of this was that cooling in low and middle income countries does not decrease neonatal mortality. None of the studies looked at long-term outcome, which is what we're really interested in. And many of the studies were small in number. The next year, in 2014, there was another meta-analysis that was published by Alan Hall from South Africa, his group. They looked at all the trials that use low technology methods, basically cool gel packs at that point of time. Face changing material has not really come out. And they found that actually there was a reduction in immediate mortality at the time of hospital discharge with a relative risk of 0.6 and a decreased mortality of 6 to 24 months with a relative risk of 0.63. However, most of this was influenced, as you can see, by one trial, which is Jacobs and et al. At 2011, which was the ICE trial, which actually looked at cool gel packs, but it was done in Australia and Canada. This is something that is difficult for us to say that it's the same in low control trial. They looked at 18-month outcome using the DASI, and what they found was that there was a significant, about 20% reduction in mortality and a 70% reduction in neurological abnormality at 18 months when those who were given cooling, which is quite an effect size. However, what the neurological abnormality was is not clearly defined, but I assume that it is abnormal DASI score. We published the thin study also this year in the Archives of Disease in Childhood, Fetal and Neonatal Edition. And this was a thin study which was again a randomized controlled trial. We randomized 50 babies, 25 to hypothermia and 25 to standard care. Babies who fulfill the criteria for cooling staging. These babies were randomized and put into either cooling or standard care. Those who were cooled to 33.5 degrees for 72 hours within 6 hours of life, and then rewarmed slowly over the next 12 hours. Those in the standard group were maintained at 37 degrees, which was and the temperatures in both groups were continuously monitored for the first 90 hours. We recorded all complications. Standard of care, the treatment for both groups were the same other than the cooling. The primary outcome that we looked at was what is called fractional anisotropy using diffusion tensor imaging. So this is an MRI biomarker, which is what it does. It looks as actually the amount, it quantitates.
The slides are not
Sorry?
moving in there.
No, I'm still talking on this slide.
Okay, fine.
What it does is it quantitates what fractional anisotropy does is what is called tract-based spatial statistics, which actually quantifies the exact amount of brain damage. That's in very simplistic terms, and it uses an automated system to do this. The advantage of using this biomarker is the sample size needed to make a difference for a neuroprotective agent is as small as 10 in each group. So that is why we chose a sample size of 25 in each group, because this would give us a 90% power to detect a 10% change. So when you look at the primary outcome, what did we see? What we saw was there was a significant difference in the fractional anisotropy and the mean diffusibility between the two groups. And the main thing was, it was in except for the corpus callosum, the plic, the thalamus, the midbrain, the lentiform nucleus, all of them, there was a definite significant difference in the MRI changes in those who are cooled versus those who are not cooled. Our secondary outcome, we followed up these babies periodically every 3 months till 18 months of age. We did a general movements assessment at 3 months, and we also did a Bailey's at 18 to 24 months. The MRI outcomes, both the conventional and the TBSS was blinded, was done by the group in Norway and UK. The long-term follow-up was done by the developmental pediatrician and the clinical psychologist in Velo, who are also blinded to which group these babies were in. So what did we see? What we saw was the composite outcome of death and disability was significantly different between the two groups. So there's about more than 50% reduction in death and disability in those who were cooled as compared to those who were not cooled. And if you look at the conventional MRI, remember that the secondary outcomes we were not powered to detect, but if you look at the conventional MRI, again, there was a significant difference between the percentage of babies who had moderate or severe abnormality in the MRI. So 43% versus 9%, and this was statistically significant. What is more interesting also was the pattern of MRI injury. So as I mentioned before, one of the theory is that if you have infection or if you have small for gestational age, your brain has already suffered an insult, and therefore cooling doesn't work. Now we know that acute asphyxia damages the basal ganglia and the thalamus, whereas the chronic asphyxia, or what we expect to see in SGA babies, is white matter injury. But what we found was that 65% of the babies actually had basal ganglia or global injury, as compared to only less than 20% who had white matter injury, suggesting that this was majority of babies in a low resource setting also suffer acute asphyxia. So what did this RCT show us in the end of it? What we saw was, as I mentioned, pattern of injury on MRI suggests acute injury similar to the high income countries. And cool babies have less injury on MRI, both on conventional and fractional anisotropy. And there was a decreased composite outcome of death and disability at 18 months. So that brings me to the end of the first question. That is, should we cool babies in low and middle income countries? Hopefully, if we repoll, I hope that I have convinced people that in an NICU setting, so I need to be careful about what I say, in an NICU setting where we have adequate intensive care, in a controlled hypothermia does improve efficacy in those babies who suffer from HIE. So safety, feasibility, and efficacy, I think, has been adequately demonstrated. And I do know that the Helix trial is awaited. We need to see the results. But again, I'll stress on the settings, because these studies have all been done in good neonatal intensive care setting. The Helix trials is more in a public hospital setup. So we'll go to the next question. So before we start addressing the next question, can we have a poll on this? Where should babies be cooled? Level 3 NICU, level 2 special care nursery, either of the above? Okay, it's interesting to see that 21% feel that you can cool in a special level 2 nursery also. Interesting to see that. Anyway, we will go to. So when we address the question, where should we cool babies? I think that there is no doubt that these babies are all very sick babies. There's no doubt about it. It is not just the cooling process. The process of looking after an asphyxiate babies requires quite a lot of intensive care. And on top of that, cooling produces its own side effect, which needs to be looked after. So a level 3 NICU could be various level 3 NICUs, but what they should be, it's mandatory that these places where you cool babies should be able to provide ventilation, should be able to have central venous and arterial access, should be able to administer inotropes, because many of these babies have hypotension, should be able to give blood product support, because many of these babies bleed, should have adequate nursing care, because cooling babies, especially if you're using low-tech instruments or equipment, need much more intensive nursing care. You should be able to continuously monitor vitals. It's not just intermittent. You need to have continuous monitoring of vitals, because things can change very fast. And you must be able to offer long-term neurodevelopmental follow-up. Amplitude integrated EEG is preferable, but not mandatory, as is also an MRI. It's preferable, but not mandatory. Now, this can be contested about the MRI, but we'll address that a little later. The third question is, who should be cooled? That is, which are the babies that we should select for cooling? And I'm not sure if we are able to get this poll working. Were we able to get this poll working?
No, there is a snag.
Okay, so we will continue. That's okay. We will continue in that. I will not pause. Okay. So if we look at who are the babies that we should cool, like we have ABC, airway, breathing, and circulation. We have A, but it doesn't have it doesn't fit A. But I have an A, B, and C. A is the mandatory criteria. So the babies that we cool are basically the term and near-term babies. We do not cool preterm babies as yet. We do not have evidence, and there is probably more harm than benefit by cooling preterm babies. So this baby should be more than 35 weeks, should have more than weight of more than 1.8 kilos, because the smaller the baby, the more the complications. And also the cooling should be started within the first 6 hours of life. Now, the reason why the first 6 hours of life is because of, it's initially based on animal experiments that showed that when you have sheep, lamb who were cooled, the benefit of cooling went away if they were cooled beyond 5.5 hours of age. And this is to do with the latent period. So we are trying to start the process before the secondary energy failure. So we need, the latent period is about 4 to 6 hours. So we try to catch them. we do know also that if you cool within the first 3 hours, you get better benefit than if you cool between 3 to 6 hours. So that's the second point that we need to keep in mind. And the third thing is the randomized control trial by the NICHD, which looked at cooling between 6 to 24 hours, did not show that much benefit. Okay, there was only a 2% benefit, which was not really that much. So I think we should still follow the criteria that within 6 hours of life. There has been a therapeutic drift, even in all the high income countries. So people, even if they come at 7-8 hours, are still cooling. But we need to keep in mind that as far as possible, we have to try to see whether we can cool within the first 6 hours of life. So the mandatory criteria is gestation more than 35 weeks, birth weight more than 1.8 kilos, and within the first 6 hours of life. The second is physiological criteria. So it could be any one of these following criteria, and is slightly different from what the trials and the Western countries go, because they do not have this whole group of babies that we do not have APGAR scores outborn. So the commonest clinical presentation in India would be a baby coming in 3 hours, 4 hours, 5 hours of age with seizures. And we have this history of not having cried at birth or having required resuscitation. The APGAR scores given is usually not accurate. So this is a group of babies that is very, very peculiar to our setting. So I will first talk about inborn. So if you have the facility of having inborn baby, or rather the advantage of having inborn babies, if the APGAR score at 5 minutes is less than equal to 5. So this is another thing. So many people take 10 minutes, and most of the trials has done 10 minutes. But we know that a 5-minute APGAR is probably will have less false negatives, in the sense that it has casts a wider net. So if you go by the 5-minute APGAR less than 5 and abnormal neurology, you're more likely to recruit the correct amount of babies. So either a 10-minute or a 5-minute APGAR, we follow the 5-minute APGAR less than 5. If you have a cot pH or a gas within the first 1 hour of life, if the pH is less than 7 or the base deficit more than 12, and if you're continuing to require resuscitation or positive pressure ventilation at 10 minutes of age. So this is the criteria which should fulfill the physiological criteria. For outborn babies, generally we do not have the APGAR score. So usually we have some history of not having cried at birth, baby not breathing, required some assistance, and this is a clue that tells us that baby has probably suffered asphyxia. The third is the neurological criteria, which is a presence of moderate or severe encephalopathy or any seizures. A baby has seizures, automatically it's classified as having abnormal neurology, or you must examine the baby and demonstrate moderate or severe encephalopathy. So how do you demonstrate moderate or severe encephalopathy? So the two large trials, the TOBY trial and NICHD trial, approach it slightly differently. The TOBY trial looked at any altered state of consciousness, so any lethargy, stupor, or coma, and at least one of either hypotonia, abnormal reflexes, absent or weak suck, or clinical seizures. And they also had an AEG criteria. The NICHD criteria had what is called the modified Sarnath staging, and they did not have an AEG criteria at all. So to recruit a baby for cooling, the NICHD just used the clinical Sarnath staging. So here you have six areas: level of consciousness, spontaneous activity, posture, tone, primitive reflexes, autonomic system. So if in any of the 6, 3 out of the 6 either are moderate or severe, then you classify them as abnormal neurology. Some people also do the Thompson score, but this is not very popular. And if a score is more than 8, would fulfill the criteria for cooling. The advantage of the Thompson score is that it gives you a number, and that number you can follow up to see if the baby is worsening or getting better. So once again, you have ABC, and you have to have all fulfilled, not just one. So you have the mandatory criteria of more than 35 weeks, more than 1.8 kilos within 6 hours. You have a physiological criteria of a low APGAR or low cot pH, or not having cried at birth or required resuscitation. And you must have abnormal neurology. So you cannot cool a baby just based on low APGAR or low cot pH. that baby must have abnormal neurology, moderate or severe, and based on either the Sarnath staging or the TOBI which I showed you. Now, Dr. Vishnu Bhatt mentioned that we should also know who not to cool. So that's also very important. Case selection, not only who to cool, but who not to cool. So less than 35 weeks, less than 1.8 kilos, and more than 6 hours of age should not be offered cooling. If you have major congenital abnormality, so how do we decide whether they would benefit or it would do more harm? You can just ask yourself the question, is this major congenital anomaly something that I would offer intensive care? If it's an anomaly that you would offer intensive care ordinarily, if that baby is asphyxiated, then maybe the benefit of therapeutic hypothermia should be offered. Imperforate anus gives us a technical difficulty of not being able to monitor rectal thermometer temperature, but this can be bypassed by having a esophageal probe, which is not easily available, but it can be done. The other thing is, if you have a coagulopathy with active bleeding, what we have seen is those babies who are already bleeding with coagulopathy, cooling really worsens it. And a couple of babies that we have lost has been because of bleeding. And we've had to bail out early because of this. The other thing is severe PPHN. So you could, high frequency and nitric and cooling is possible with PPHN, but we do know that cooling can worsen PPHN. So generally, if a baby is hypoxic and extreme PPHN, we would think twice before offering therapeutic hypothermia. Other thing is those in extremis, that is those who are extremely sick. So in Vellore, what we used to do was, any baby who has not established spontaneous respiration by 30 minutes, we would not offer intensive care and we would not offer cooling. So this is our babies that have severe encephalopathy, and the benefit that you get in severe encephalopathy is not as good as that you get in moderate encephalopathy. So you need to choose to decide. So these are not fixed criteria. I mean, these are the criteria that you have to work around depending on where you work and what setting you are doing and what you feel about the ethics of this. Now, the process of cooling involves three things: the actual process of cooling, the equipment that you use, and what is the monitoring that you do for these babies. Again, I think the poll is not holding, so we'll go to the next. So when you look at the process of cooling, there are three phases in cooling. One is the first phase is the induction phase, second phase is the maintenance phase, and third phase is the rewarming phase. Now, the induction phase, as I mentioned already, earlier the cooling, better the outcome. So you need to try to get the baby down to target temperature, that is 33 to 34, 33.5 to be exact, as soon as possible. So if as far as possible, most people try to aim for at least by 30 minutes. It should be as fast as possible. And that's why the servo controlled devices, I think, are much better than that. They really bring down the temperature quite fast. Now, the second thing is, during the induction phase, do you offer passive cooling post resuscitation? Now, this is something that needs to be dealt with unit by unit because it depends. So what we do know that many babies who have a low Apgar or low cord pH, many of them actually do not develop encephalopathy. They recover or they have mild encephalopathy. So if you have a baby who has got significant asphyxia, significant resuscitation, you could turn off the warmer as you wait for the neurology to be checked before you start active cooling. Third thing is, you need to do a neurological examination before induction and you need to document it. It's important that you document. So in Vellore, what we have is a formal Sarnath staging where we tick every half an hour to 1 hour when the baby comes to the unit to demonstrate that we have fulfilled 3 out of the 6 before we start active cooling. So it's important to do a formal neurological examination and document it before we do it. You must remember, whatever it is, servo or non-servo, this initial induction phase is always a little bit of overshoot before it stabilizes to the 33.5. The second phase is the maintenance phase. So we maintain therapeutic hypothermia for 72 hours. So within 6 hours, for 72 hours, and the temperature that we aim is 33.5, giving a leeway of 0.5 degrees on either side, so 33 to 34 degrees. It is important during the maintenance phase to prevent fluctuations. What we want is babies in this gray zone, temperature steady within this gray zone. We don't want to swinging up and down, because whatever neuroprotection that you get is lost. And that has been shown in animal studies. For this, servo control is better, no doubt about it. It's much more stable as compared to low-cost equipment. During the maintenance phase, you should also avoid cold injury to the skin. So it's important that you check the skin and you change position every 4 hours at least. You must be careful about displacement of temperature probe, and this is important both in the servo and non-servo, because all your feedback and all your manipulation is based on what your rectal thermometer or esophageal thermometer is reading. There's a lot of nursing involved, especially if you're using low-tech devices, and monitoring has to be constant. I'll come to the monitoring a little later, but this is very important. The rewarming phase is probably the most important, because of the fact that we do know that rapid rewarming in adult studies have resulted in poor outcome in the loss of the neuroprotection. We know that there is hypotension due to vasodilatation. There is rebound hyperkalemia, hypoglycemia that has been noted, and rebound seizures as well has been reported during rewarming if it is done rapidly. So what is the rate at which you rewarm? You rewarm at the rate of 0.2 to 0.5 degrees per hour. So not more than 0.5 per hour. The slower it is, doesn't matter. So generally we aim for 0.2 per hour, so that if at all it crosses, that doesn't matter, but it should not be more than 0.5. So it takes about 8 to 12 hours for the baby to come back to normal temperature. Other thing important to remember during the rewarming is that you need to monitor for a few hours after the normothermia to prevent rebound hypothermia. That's important, because what happens is once you hit the normal temperature, if you stop monitoring, it will continue to rise. And we know there are excellent studies that have shown that if you have hyperthermia, your neurodevelopment is worse than if you have even normothermia. So you lose the benefit of cooling if you let the baby rebound to hyperthermia. So it's important to monitor the baby, continue to monitor the rectal temperature for several hours after the baby has reached the normothermia after rewarming. Now, second thing we said was equipment. So we said the process, second is the equipment. So if you look at the equipment, initially everybody talks about head cooling when you talk about therapeutic hypothermia, because that is the first thing that was introduced. So this is the Olympic cool cap system that was the first FDA approved equipment. So what it does is runs cooled liquid around the scalp, and that cools the body also down. But there are some concerns. One is that you cannot put AEG, you cannot do scans, difficult do ultrasound, so it limits your access. The second concern is the fact that because of the scalp being very cold, the superficial layer of the brain is much colder than the deep structures, the basal ganglia and thalamus. That's why I really want cooling. The gradient may not reach there. That is a concern, though the studies have shown no difference in the outcome. So this is actually gone out of fashion. Also, this equipment is quite expensive. 25 lakhs was what they were quoting last I knew. So this has gone out of fashion. Not even in the US, where people are doing head cooling, have switched over to whole body cooling. So if you look at whole body cooling, so the servo control devices are available. The three standard ones are the Blanketrol system, the Tecotherm system, and the Critical system. These are all servo controlled. They are automatic. They usually work on the principle you have a jacket, which you circulate cold water or coolant. You have a rectal probe that feeds back to the machine, and if the baby's temperature goes up, the fluid temperature comes down, and that feedback keeps the baby's temperature 33.5 degrees for 72 hours. And the rewarming also, you can program to rewarm by 0.5 centimeters per hour. The problem is, of course, because they're servo controlled, they are produced by companies, they're expensive, anywhere between 15 to 18 lakhs when I last looked at it. May have become less now, but it's still quite expensive. And the problem is that quite often when you have asphyxiated babies, like anything in neonatology, they'll come 2-3 at a time. So if you have one device, then you'll have to, what do you do for the second baby or the third baby that is in the unit that needs cooling? I'm not going to go further on these server control devices because they're really easy to understand. And the focus of this talk is what is the alternative equipment that we could use in low resource settings. Now, if you look at the equipment that you could use in low resource settings, the ones that have some data on it is, one is passive cooling. So you could have babies who are just left exposed in air conditioned rooms. Here the problem is that not all of them will reach target temperature, and you have no control over the temperature. One thing is that all asphyxiated babies in the first 6 to 12 hours after birth will drop their temperature. That's normal. So you will achieve maybe the target temperature for the first few hours, but after that is very difficult. People have described pots. There's a publication where the pots have been used to cool piglets. Alan Horn and his group in South Africa has produced a servo control fan. People have described water bottles, but I'm not going to talk about this because it's not really used that much. What we do use is cool gel packs and phase changing material. So I'll just concentrate on this. So if you look at cool gel packs, so cool gel packs are those that come in vaccine in vaccine containers. So they are frozen and kept alongside vaccines to keep them cold. So these are actually frozen gels or frozen ice packs, and they're very, very cold. Obviously, they're in the freezing temperature of 0 degrees. So you cannot keep them directly on the baby. Some people keep them around them. So, and what we do in Vellore, we used to do before when we were using cool gel packs in between 2007 and 9, was we used to wrap them in clean cloth and keep them in contact with the baby, so that is not very cold, but it draws the heat from the baby and cools the baby down. So this is how we use cool gel packs. The problem with cool gel packs is that it does not last more than 2 to 3 hours. You need to change them again, and they're very cold, and quite a lot of the babies shivered. The temperature tends to fall very rapidly down, and there are quite a lot of swings. If you look at the safety and feasibility data of cool gel packs, that is Indian data, we have published our study, and what we got initially, we were aiming 30 degrees and we got 32.9 plus or minus 0.22, quite a narrow standard deviation. The JIPMA, Dr. Butt's group has published several studies using cool gel packs. We have studies from St. John's and Manipal, all have used cool gel pack and found that the temperature control is within accepted. So you have a standard deviation of 0.34. If you look at most trials, the standard deviation was around 0.3 to 0.4. So this is quite acceptable what standard deviation we have. So it is feasible to use cool gel packs. It's not that we cannot use it. The other option, so when we started using cool gel packs, what we found was that it was quite labor intensive. So every 2-3 hours, somebody had to change the nurses had to change the cool gel packs. Quite often when you change a new pack, the temperature will drop suddenly down. And it was not as easy as we wanted it to be. So that's when we started looking at other alternatives. So we came across the study. There was a piglet study that was published in Archives, which they cooled using phase-changing materials from Sweden. The same PCM was also used in Calicut by Sudhin Thail. So, but we had heard about the piglet study, so we actually I Googled and found out that there was one company in Gurgaon which was producing phase-changing material for the industry. So what is phase-changing material? Phase-changing material is just anything that will act like a heat sink. So as the solid absorbs heat, it changes from solid to liquid. That's the phase change, absorbing heat till it changes completely to liquid. So if you take ice also is the phase-changing material. So you keep a hot object on ice. That ice will absorb the heat from the hot object and continue to absorb till every last bit of ice changes to water. The temperature of that will not change. It will continue to absorb heat. So that the problem with ice is it's very cold, it's 0. So that means if you keep a baby on it, it'll keep on absorbing heat till the baby also reaches 0. I mean, theoretically. So when you say phase changing material, these are all like salt hydrates. So there is organic and non-organic. So the organic are fatty esters and the non-organic are salt hydrates. So they have a melting point. So you can make a phase changing material with whatever melting point you want. So we asked the company to give us a melting point of 32, and we tried. It didn't work. So with many trial and error, finally we found one phase changing material of melting point 31 which worked. And we did a study, the 9 babies, and we built this bed. So this was the same CMC phase changing material bed which we presented in the 2012 Neocon and won the innovation award. So this was the bed that we initially built. So we had a insulated material here with a pouch where we kept the phase changing material, and the baby lay on top of this. So the material here is a good conductor. So it conducts the heat from the baby who lies on this to the PCM. The PCM absorbs the heat till it melts completely. So we had to figure out how many kilograms to keep. It was trial and error. Finally, we worked out, and this is what we got. So this is our publication which we published in Neonatology, and you can see that the babies maintain a temperature 33.45 plus or minus 0.26, which was excellent, comparable to server controlled devices. This we then passed on to the industry who built the Mira cradle, and they actually came up with the idea of putting 2 types, the 21, because what we found with our initial thing was the induction phase was much longer than what we wanted. It took us about 90 minutes to get the baby to target temperature when we wanted actually 30 minutes. So we used cascaded system. So used a 21 degree melting point phase changing material on top of the 29-degree one, so that the initial part, the heat is absorbed fast for induction, and this melts, and then this takes over. So the Mira cradle was then produced and is now being marketed. We also looked at the temperature differences between those that were cooled with cool gel packs and those that were cooled with phase changing material. And as you can see that the standard deviation with the cool gel pack was 0.4, whereas it was much narrower. You can see in the diagram there is much narrower interval and much more stable with phase changing material. We then went and we did a multicentric trial in which Manoj also was part of, where we looked at 10 centers throughout India, and we demonstrated that it was not only CMC who could use it, but other centers could also produce the similar results. So here that was 33.5 plus or minus 0.39. Now, low-cost devices, cool gel packs and phase changing material, there are some concerns. It's not that they are the best. There is more nursing input and they are more labor intensive, especially with cool gel packs. Increased shivering has been reported with cool gel pack, but this is not our experiences phase changing material. Precise control is definitely less likely than servo controlled devices, obviously. And it does not remove the need for intensive care and monitoring. Just because you have a cheap device doesn't mean that you can use it everywhere. It's still, these babies are sick and need intensive care and monitoring. Now, coming to the adverse effects of hypothermia, if you look at so cooling is actually counterintuitive for neonatologists. We have always been taught for many years that keep the babies warm and sweet. So when we say the adverse effects of hypothermia, if you look at any textbook, this is what you'll find: increased mortality, sclerema. This is a baby with sclerema. Subcutaneous fat necrosis, skin erythema, pulmonary hemorrhage, renal failure, increased blood viscosity, DIC, hypoglycemia, acid-base and electrolyte disturbances, increased risk of infection, hypotension, cardiac arrest, VTAC, pulmonary vasoconstriction. The list goes on. But if you actually look at the studies, what they've shown is only a sinus bradycardia, which is significant, but that is not clinically relevant. It's just the heart rate is low for these babies because their metabolism is low. There's some thrombocytopenia, again significant statistically, but these did not clinically bleed. And there was an increased trend to pulmonary hypertension, PPHN. Now, why is this? This is because of the fact the hypothermia that is here is controlled hypothermia. It's not uncontrolled hypothermia. Now, what is necessary to know also is the fact that swings in temperature should not be there as far as possible, because swinging temperatures are associated with cardiovascular instability and emergence or re-emergence of seizures. And also there is a possible loss of neuroprotection. Shivering and pain also may worsen outcome, and sedation and analgesia are very important. Now, if you go to monitoring, what do you monitor? So temperature needs to be monitored continuously, and this needs to be core temperature. Skin temperature is not adequate, and we have shown in our studies that skin temperature they correlate. They are not precise. They are not accurate or precise. So you need to have continuous rectal or esophageal temperature with the skin as a backup. We need to record every 15 minutes still for the first 4 hours the stability is occurred, and then you need to record every 1 hour till rewarming is over. Normally what we would do is we will continue to record till about 96 hours. Vital signs need to be monitored continuously: heart rate, oxygen, blood pressure, and urine output. So we should have ECG leads. You should have invasive blood pressure monitoring with arterial line. This is what we advise. The reason being is that there are centers who do not use this and have reported picking up hypotension much late. Remember that cool babies is very difficult to go by clinical signs, because the CRT will be prolonged. They will look cyanosed, and so it's always good to have invasive blood pressure monitoring. Central access is good. You need to have saturation monitoring and urinary catheterization or bag monitoring, and all this has to be recorded hourly. You need to change position and check skin for cold injury at least every 4 hours. Neurology has to be assessed at least once a day till rewarming is finished. You can use the Sarnath or the Thompson. So we normally recruit with Sarnath and then monitor. At that time, when we start cooling, we document Thompson, and we continue to document Thompson because it gives you a total score, which is easy to keep track of. At 1 week of age or the time of discharge, it is good to have a formal neurological assessment. So either the amyl Tyson, Hammersmith, or the TIMP. This is what we do. We use the amyl Tyson and TIMP. Hammersmith, I know that SRMC uses this. So this is something that we need to do as a formal neurological assessment at the time of discharge. AEG, if it's available, is good to do. And this is how we would record AEG at the start of cooling, AEG at 24 hours, AEG at 48 hours, etc. So that it helps us in the prognostication. Neuroimaging, we would do an ultrasound with the Doppler in the initial part, but more often between day 5 to 7, we would do an MRI with the MRS. Lab monitoring is important. Babies can get hypo or hyperglycemia. Both of it is well described, and both of it is said to worsen outcomes. So it's important to monitor blood sugars, important to monitor counts, especially platelet counts can drop. Coagulopathy needs to be treated aggressively, and you need to monitor electrolytes and creatinine. We do a liver function test sometimes and troponin and baseline, but this may not always be necessary. Blood gases, usually we monitor blood gases till they are normalized. Feeding. So initially when we started cooling babies, in the first few years, we didn't feed, but as we got more confident, we realized that we can feed. We do feed stable babies who are stable, hemodynamically stable. We give trophic feeds during the cooling, and after rewarming, we grade up on feeds. It's important to provide sedation and analgesia if necessary. So if a baby is ventilated, morphine or fentanyl infusion. The baby is not ventilated, and if there is a lot of shivering and signs of distress, then we use chloral hydrate and paracetamol. So the signs would be any tachycardia. So normally when you cool babies, the heart rate is usually around 80 to 100. If you have tachycardia, it's either pain or infection, or the baby does not have encephalopathy. That's what we have found out. So if there's tachycardia, irritability, grimacing, or shivering, we would consider giving some pain relief in the form of paracetamol or chloral hydrate, or morphine and fentanyl if they're ventilated. Remember that drugs that are eliminated through the P450 enzyme symptom of the liver is depressed. So morphine levels, phenobarb levels, all these levels are much, much higher than normally expected. So you need to be careful about what drugs, when you're giving drugs in these babies. Follow-up. This is our sort of follow-up that we usually do. We see them at 3 months, 6 months, 9 months, 12 months, 15 months, and 18 to 24 months. At 18 to 24 months, we normally do a Bailey's or a Griffith. Some people use the Darcy. At 3 months, we would do a general movements assessment. So this is a good thing to do for prognostication. We can also do amyl-dyson, and other visits we would do other than anthropo. So every time it's important to follow up the head growth is very important because that correlates with the outcome. Other than anthropometry, you can also do a screening test in the other times that they come till you do the formal Bailey's at 18 to 24 months. Now the question is, do you need AEG and MRI? AEG is a useful adjuvant, no doubt about it, but it's not a must. So AEG you do not need AEG to recruit babies for cooling. Even though the Toby trial and many people do use it, it is not a must. It's useful for prognosis, it's useful for seizure detection, but it's not a must. MRI, if you have the facility, I think as far as possible, all babies who have HIE and are cooled should have an MRI between day 5 to 7, especially but if the diagnosis is in doubt. So if you don't know, if you're not 100% sure with asphyxia, if there's alternative diagnosis possible, it's useful to have an MRI. And if you want early prognosis, especially if you're considering withdrawal of care, it's very useful to have an MRI. Now, one other thing that we looked at in thin study was comparing the MRI with the general movements assessment. So for those of you, most of you will be aware of what general movements is. General movements is what is called the prectal movements. So this is looking at doing a video of the baby at around 12 to 15 weeks, corrected gestation. And they have what is called fidgety movements. So the absence of fidgety movements predicts cerebral palsy. This has been shown in a lot of studies for preterm babies. And what we did was we looked at MRI and compared MRI with general movement assessment. And what we found was the negative predictive value of absent fidgety movements on general movement assessment in our cohort of these 50 babies that we saw was same as that for those who had severely abnormal, moderate or severe MRI. So if you do not have the facilities of MRI, on follow-up, it is excellent idea to get general movements assessment done because that has a same negative predictive value. Of course, this can be done, the general movements is done only at around 3 months. So you will not have an early prognosis, what MRI will give you in the first week of life. But if for follow-up, this is an excellent tool that can be used, which is as good as MRI in predicting outcome. So in conclusion, I will just put up the questions again, and I hope you have got the answers. Should you cool babies? I've given you evidence to show that there is safety, efficacy, and feasibility in low middle income countries in a NICU setting. What facilities and settings? It's very, very important that you have settings and facilities that provide good intensive care where you can cool babies. Are there any differences? I talked about the fact that you need to have babies who are more than 35 weeks, more than 1.8 kilos within 6 hours of age, either a low UPGAR or a low cord pH, or an outborn babies not having cried at birth, but also have to demonstrate abnormal neurology, not just low UPGAR or cord pH. Any alternatives? Yes, there are alternatives which work well. Only thing, they are not as good as servo and they need more intensive nursing care and input. How do you monitor and follow up? We went through that. It's very important that you have good monitoring and good follow-up in place when you cool babies. And AEG is not a must. MRI is very useful, but you can manage without it. Thank you. I would like to acknowledge the CMC Vellore faculty, Dr. Jana, my mentor, Sridhar, Anil, and Manish, my colleagues for many years, because all the work that I've done with cooling HIE has been possible because of them. Also want to acknowledge the nurses, my other colleagues, and the parents and babies that have been part of the research, and also my wife who made the slides. Thank you.
I think we should congratulate Niranjan for covering the topic extensively. There are many questions which the participants have put up. He has covered almost all important issues like using servo control, non-servo control. In Jipmer, we have tried gel packs initially, Miracradle, Tecotherm, but outcome is almost same. It only depends upon how you are able to monitor and look after the babies. That's the most important thing. So he has highlighted why the temperature should be constantly monitored and maintained, and also the slow rewarming, which is important, because suddenly eureka, you're done cooling, you leave, you may go into hypothermia and create a problem. And he also talked about selective head cooling and whole body cooling. Now, selective head cooling is no longer used, as he said, because there are MRI studies which showed that there is a difference between cooled on the head cool and the whole body cooling. Body cooling is much more effective because the differential cooling in the brain is not there, and the MRI changes showed that there are differences, although morbidity and mortality is not much statistically significant. And he has also highlighted why shivering and overcooling, all this should be avoided because it will be counterproductive. Now we'll take a few questions. My co-chairperson Sunil Kishore is also there. First few questions I will ask from the audience. Niranjan will answer. So does therapeutic hypothermia increase the need of mechanical ventilation? Dr. Niranjan?
Yeah. So if you look at the Western studies, about 60 to 80% of babies who were cooled were ventilated. Now, that is not our experience. In our experience, and I think Dr. Vishnu Bhatt can also concur, has been that about 20% of our babies are ventilated. So, to answer your question, does cooling increase the need for ventilation? If it does, it's very marginal. It's not very much at all. So, I would not ventilate a baby just because we are cooling the baby. I would not do that. The indication for ventilation would be other things.
So basically, I agree with what Niranjan says. It does not increase the need for ventilation, but we may cool the babies who need ventilation, because with the ventilation also you may cool. But obviously, it does not increase. Maybe occasional case of PAPH, some problem may develop. Otherwise, it does not. Should we create a therapeutic hypothermia center? What is your opinion on that?
Well, so I think the question is whether we should have regional areas, regional centers. So that is the point that Dr. Vishnu Bhatt also pointed out, that transport is, there are many, many things that need to be placed before we have. So most Western countries, and even here in Melbourne, it is only the NICUs that cool. So any baby who is in the community or in a peripheral hospital who fulfills the criteria for cooling will be transported by the transport team within 6 hours, and they would cool during transport. And that's the model that works in most places, and which is obviously the best model in the sense that if you develop one center that cools, they will do it much better than if you cool 1 or 2 babies in a year. So that is a model that may not always be practical. So in India, it is very difficult because the facilities, the infrastructure is very different. So if you go to a rural area, say in one of the states that have not much of health structure, the priority there is providing care for the mothers, antenatal care, providing safe delivery. You won't even raise the issue of cooling because it's probably not safe there. You do not have a NICU in the next 200, 300 kilometers. You can't take a baby there. You would not do it. Whereas you have cities, in urban area, you have 3 or 4 centers that are doing good cooling. Then you should educate the obstetricians, the pediatricians who cannot do cooling to say, don't keep those babies here. This is these babies need to be cooled, and then organize transport for them. So it will be a mixture of the models that will work in our country.
If we anticipate asphyxia, probably it is better to refer the mother early so that she can deliver in a center where cooling can be done. Otherwise, as you rightly put it, we should develop more centers where cooling can be done, but it cannot be done at primary health center or where there are no facility, as he has rightly put it. We should have the basic facilities to look after a sick baby before we cool. That is very important. Now, the next question, is between 6 and 24 hours cooling is beneficial, or is it harmful after 6 hours, but within
So the
24?
NICHD study recruited babies between 6 to 24 hours. And what they found was that the benefit was marginal. So it's not harm, it's not more harm. I wouldn't say more harm, but the benefit was marginal. Now, the first priority is for all doctors is do no harm. So we have to weigh the harms and benefits. So if you are a center that you've been cooling for many years and you have a baby who comes at 8 hours of age, you might decide that you want to offer that. So if you ask me what I would do, then in Vellore we were not doing that. If a baby comes beyond 6.5, 7 hours maximum, we would not, knowing the fact that this is a process of 72 hours. It has its own effect. So we would not offer. There is not enough evidence for that.
Yeah. So now the next question is, suppose if there is after asphyxia, whether you do passive cooling.
Yeah, I think yeah. So when you say
I think you already covered this point.
Yeah, I did cover that. So quickly, what we know is that passive cooling is unregulated, and the passive cooling that has been done in transport, there are 3 or 4 studies that have shown that babies have arrived at temperatures that are not acceptable. So passive cooling is not, don't have control over the situation. You may hit the target temperature, you may not hit the target temperature. You could do passive cooling while waiting for active cooling. Like, when you are deciding about what to do, you could do passive cooling, turn up. But even if you do that, whatever passive cooling you do, you still need to monitor the rectal core temperature. That is very important, because if you don't monitor the core temperature, you don't know what temperature the baby is heading to, and you may cause, definitely if the temperature drops less than 32, that is going to harm the baby.
Now you answered already after 6 hours, but there is one more question on 6 to 12 hours. Of course, there are some minimal evidence may be there, but as he rightly put it, after 6 hours is very difficult to decide. And of course, if you have facility for more cooling babies, probably you can try, because a little benefit the baby may get, but definitely it is not going to be useful that much after 6 hours. As he rightly said, earlier the better. Within 6 hours, 3 hours if you can do, it is still better. There is
I
one
think
more. Yeah.
I think the questions are that question. I understand why these questions are coming, because
Study on that.
most outborn babies are come late. So that is a reason. But there is not enough evidence to show that if you cool babies after 6 hours, that is going to do them that much benefit.
Now there is one more question asking that up to 6 hours the baby looked all right with the asphyxia, but after that it does convulsion, what to do? So
if you have a baby after 6 hours having seizures, you've lost the benefit of cooling. So we don't cool babies like that, and it happens. It's not uncommon. So what we need to do is, what you could do is, if it is an inborn baby, for outborn babies you have nothing you can do, but inborn baby, if a baby fulfills the physiological criteria, then it's important to monitor the baby every half an hour to 1 hour, so that even before they have seizures, if they demonstrate abnormal tone, if they are drowsy, they would still fulfill criteria without seizures. But if a baby is coming to you without any encephalopathy and then developing seizures, it may not be asphyxia. It could be other things also. So if a baby, we would not cool a baby who comes at 8 hours with seizures. Unlikely to do that.
Yeah, I agree with you. We should look for other causes, or the resident was sleeping. He did not monitor properly. That also can happen. See, after the asphyxia, he looked all right. Many babies after resuscitation, they look all right. Then you leave him. Then the nurse calls, he has got convulsion. So many times it is because of improper monitoring of these babies.
Yeah. Yes,
Now,
that is important thing. That's very important to monitor.
Now I will leave some question to Sunil Kishore. I think he can continue for some more, because we have got another 15 minutes. Yes. Sunil Kishore, you can ask the next questions. You can unmute yourself.
Yeah, sure. Dr. Vijay Krishnan is asking, do you routinely take consent before starting cooling? So consent before cooling.
Do I take? I don't take. Meaning our unit doesn't take. Should you take? That's a debate. Uh, I can ask Dr. Vishnu Bhatt to contribute to that, because so we take consent if it is a study. So all the studies that we have done, we took consent. But once it entered a phase where we offer it for all babies, we stopped doing studies, we stopped randomizing. Once we stopped randomizing, we have stopped taking consent, because we feel that that is our standard of care, and that is there in our protocol. It is there in the entrance of the nursery that we offer therapeutic hypothermia. It's one of the things that we offer. So we do not take consent. It's like taking consent for ventilation. So if you're worried about being sued, then do you take consent for ventilation, surfactant therapy? Then take consent for cooling.
Basically, any invasive procedure or any procedure which there is harm, we should inform. It may not be written consent always, but still now it has not become a standard of care. Our associations, whether it's an NNF or IAP, NNF or whatever it is, they have not made it a mandatory thing for hypoxia. So till then, some people may consider it experimental, but once you have done studies and showed definitely better result, you can inform the parents and then definitely cool. Just like what he said, ventilation. Always you may not take a written consent, but you have to inform them definitely.
So we had talked to our legal people regarding these things, and what they said was, you do not have, if you have a guideline. So if you have a written guideline in your unit, and you have a rationale behind it, that will support you. If you want to be safe, you should take consent. There's no way. The thing is, the other way around also can come. Some parents may read Google and come and say, my baby's asphyxiated, you're not giving cooling. What about that? So it can work both ways.
Yes, sir. So in our unit also we are taking cooling we are taking consent as of now, sir. So since it is a standard of care down the line, we need to see like whether to take consent or not. Dr. Parthasarthi is asking, like, do we stop cooling if prothrombin time as well as APTT is significantly increased? If there is significant coagulopathy, shall we stop cooling?
So coagulopathy in blood test, you don't need to stop cooling. So what we have seen is, if you test these babies, about 60% of them have abnormal coagulation. That probably is because of asphyxia itself, which cooling just increases. But all the 60% do not bleed. So our protocol is, we monitor the PT-PTT. If it is abnormal, we correct it. We do not stop cooling. We would stop cooling if the baby is bleeding and we are not able to control the bleeding. So we had one baby with a large subgaleal bleed, which kept bleeding and bleeding in spite of correcting the coagulopathies. For that baby, we rewarmed the baby because we are not able to get on top of it. At that point of time, the harm seemed more than the benefit. So just for blood test coagulopathy, no. Just correct it, you don't stop cooling. But if the baby has extreme clinical signs of hypotension because of large bleeding, maybe yes.
Yeah. Dr. Kirti is asking, like, can we give formula feeds during therapeutic hypothermia if the baby is outborn?
It's a good question. I don't use formula, so I don't know. We are lucky to have breast milk bank in Vellore. So if you look at the physiology, in asphyxia, we do know that the gut injury can happen, and we do know that necrotizing enterocolitis can happen when you feed the babies. So obviously, I would be very, very careful about it. If I have express breast milk or pasteurized donor milk, I would use it for as not in full volume feeds, like a sort of trophic feed during cooling. And we really go into full volume feeds and grading up of feeds only after rewarming. I have not used formula. Dr. Vishnu Bhatt can maybe share his experience, and you also, Dr. Simsonil.
Actually, we also have breast milk bank, so there is no need in Chipmer for giving artificial feeds, as you rightly put it. But I think it is better to avoid artificial milk or formula feeds as far as possible, as you rightly put it. But in unavoidable, if you want to feed small trophic feed, it may not cause harm because you are feeding other babies, but there always risk of infection and NEC is higher. It's better to avoid. It is not necessary that you have to feed all babies during cooling. Actually, what he is talking about a trophic feeding, not full feeding. We usually avoid full feed during cooling because we are not sure whether you develop NEC or we may not develop NEC. So better to be careful.
What we are doing in our unit is like we are giving only minimal enteral nutrition, that 10 to 15 ml per kilo per day for that 72 hours period. So preferably EBM, but if not available, occasionally formula feeds. And once the baby comes out of cooling, then like your feeding protocol anyhow it will follow. And I think you have already answered, sir. Ventilation, is it not mandatory for cold babies? So you told like it's not mandatory. What are the chances of abnormal neurological outcome if MRI shows hyperintensity or changes in thalamus or basal ganglia? And what is the role of MRS? Dr. Vijay is asking.
So there are a lot of studies that gives numbers. So there are also at least 3 or 4 classifications by which you can classify the MRI damage. So if you have, basal ganglia and thalamus can also be classified as mild, moderate, and severe. And based on that, you have numbers. So if you have, what is most important is if you have plic, absence of the plic sign, that gives you a 90% chance of having cerebral palsy. Basal ganglion thalamus, I think if you have severe damage, it's more than 60% chance of having cerebral palsy. I can't remember the exact numbers, but there are several studies that gives you numbers and several classifications that you can use for that. Similarly, with MRS, I think the sensitivity specificity is about 90% of predicting outcome. And that also is a bit disputed. Some people say the Na choline ratio, some people say the lactate peak. But whatever it is, the sensitivity is around 90% for us to predict outcome.
See, we give many anticonvulsants. Sometimes neurological assessment becomes very difficult for few days after this. So MRI will definitely help you in prognostication. If there is severe damage, you know that there could be likely long-lasting issue. So as he rightly said, normally first week we will not do. At least after 5-6 days, you may do MRI. Best maybe in the second week, which may tell you the future outcome.
Among the different findings, neurological findings in MRI, like the changes in thalamus and basal ganglia are associated with profound severe asphyxia. So that's why it is associated with the poor neurological outcome as compared to selective neuronal necrosis and this thing. So definitely, like the outcome will be worse if there are changes in plic or thalamus or basal ganglia. So how frequently to monitor the electrolytes during cooling?
So when we initially started cooling, we used to monitor it every 24 hours. But as we put our numbers together and we gain more experience, we realize we don't need to do that. So what we do is we do it at 24 hours and we do it at 72 hours. That's the two times that we do our electrolytes. But most of the time, we do not have much problems with that. That has been our experience. Dr. Vishnu Bhatt and Sunil can contribute also.
Yeah, same. What you are telling is fine. See, electrolytes, of course, abnormality can occur even with hypoxia without cooling also. So people have reported hyponatremia, and if your fluid is not given, sometimes hypernatremia can occur, but mostly it is hyponatremia because of inappropriate antidiuretic hormone secretion. So it is necessary sometimes, especially a baby has got convulsions, you may think for calcium, electrolyte and all these things, because that could also be cause of convulsion in addition to hypoxia. But otherwise, routinely, it may not be needed all the time. 24 hours and 72 hours may be fine in otherwise normal baby.
Yes, sir, sure. Can Mira cradle can be used during transport, and what are the precautions to be taken if at all it's being used? Dr. Vijay is asking.
The problem is that when you use a Mira cradle, you need a heat source because sometimes the baby's temperature does drop. So, and it also is difficult to fit that cradle in a transport place. So we are we had started working on a transport model. So it would be an ideal if you had a transport incubator with a miracradle inside where you could auto regulate the temperature. But we have not used it so far. If somebody has to try it out, they can try it out, I guess.
What is the role of neurosonogram and RI? I think he's asking about resistive index in NSG. So, is there any role of NSG and RI?
So the problem with the resistive index is that cooling does not, the prognosis, when you cool babies, the RA does not correlate with prognosis, not as good as when you're not cooled. So that's the problem with RA in cooling. Neurosonogram is useful because it's bedside. You can rule out other conditions like bleeds. You can pick up hyperdensities and hypodensities in the basal ganglia and the cortex. You can pick it up if you're good. So it's a bedside tool, and I think everybody uses it. And more and more people who are trained know how to use it, and it's a easy tool to use, and does give you some information.
So, NSG is useful to exclude other causes like bleeding. And,
Yes.
yes, obviously, RI, like at that point of time, it won't help in decision making. So, anyhow, you have taken the decision of cooling, then you
Yeah,
are.
and the prognosis does not correlate. RA prognosis sensitivity is not as good when you're cooled.
Some of the questions are repeated, I think. There's one question on magnesium sulfate during cooling. I think JIPMER, we have conducted this study on magnesium sulfate and cooling. And what we noted was there is no additional benefit of magnesium sulfate along with cooling, because probably you get as much benefit as possible with the cooling. After that, probably there is not much added benefit, but maybe marginal difference may be there because slight improvement in the outcome was there, but it is not statistically significant. Yeah, continue, Sunil. Two more questions so we can
Somebody is asking as a eyeball figure. In your experience, what proportion of perinatal asphyxia babies were eligible for cooling?
So I don't have the numbers actually. So I think the question is how many babies with low Apgar and low cot pH develop HIE as compared to those who don't develop HIE. I think that's what I understand from the question. I would say, I mean, I don't have statistics in the sense I haven't looked at the data, but I would say that about 50-60% of them actually don't develop HIE. It's more of number of babies who don't develop HIE than who develop HIE, just on low cot pH and low Apgar.
See, if a baby has neurological abnormality without low blood pH and base deficit, it may be likely to be some other cause. Maybe it may be brain injury, it may be due to some primary brain problem itself. So they may not have really hypoxia as such, they may be having other problems.
Neonatal
So,
encephalopathy.
yeah, that is why he has specifically mentioned about ABG and base deficit. But in outborn baby, sometimes it becomes a problem because the baby comes late. So we don't have the ABG. So there you take a chance. You may be in the right track, you may have in the long track. So it is problem sometimes. But hypoxia babies, which how many you are cooled, you are asking questions. See, whoever fulfill the criteria, we cool, no? That's what we do. See,
I think the question was those who have perinatal asphyxia as in terms of low Apgar and low cot pH, how many of them you cool as in they who fulfill the neurological criteria? That's what I understood as.
see, Apgar is although it's objective, it becomes subjective many times because you do not really look at the watch, you do not look at the time. Then after research, maybe, okay, 1 minute, maybe this, 2 minutes, 5 minutes, maybe this, like that. You're right. Although it is objective, it often becomes subjective. So Apgar per se may not be a real indicator of asphyxia. You should look at the ABG and other things. And neurological abnormality with the low Apgar is important. Both should be there. So it is not just a neurological abnormality without asphyxia. Both asphyxia should be there and neurological abnormality also should be there. In a mild asphyxia, of course, the outcome is good whether you cool or not. So that's why many people do not advise cooling because of the side effects may be associated. But in moderate hypoxia, it is the best I think everybody must be having a similar experience who are schooling. Severe asphyxia, we cannot say this way, that way. So you should catch hold of the moderate asphyxia babies early, cool them, and you will get the best benefits of cooling. And whether it's India or USA or UK, I don't think it makes a difference. It's only the people who make the difference, not the babies. Babies are same. If you wait for American or a UK man to come and tell you cooling, you will never do anything in India, because I don't think we have any evidence for many of the practices which we are doing. We read the books, we practice. If it works, works. If it does not work, it does not work. But I think now we have so much evidence in favor of cooling, and I think JIPMER, we must have randomized more than 1,000 babies. Wherever I go, they ask, "Sir, are you sure it is will be effective? Okay, let us do one more study." So like that, we went on doing, and I think still the questions keep coming. I don't think people will be satisfied, but I think there is an end to everything, and I feel cooling is definitely effective. It should be done, and it should become a standard of care. Only thing is, there should be proper facility, as Dr. Niranjan and Dr. Sunil Kishore told. The facility should be available. That's important. And I think final comments Sushil Kumar can add, Sunil Kishore can add, and then we close probably, because we were asked to close by 6:30.
Is that, sir, somebody is asking, like, even in mild encephalopathy, HAE stage 1, should we offer cooling or not? So I think sir was already mentioned.
I think the background is that there are a few studies that have come out recently that shows that initially, when we say mild encephalopathy, the thought was that they're all normal. But there are recent studies, MRI and clinical studies, that show that they have MRI changes, and they do have problems like learning disabilities and things like that later in life. There is I think there will be a trial soon on mild encephalopathy, the randomization, but the numbers are going to be huge, because if you're going to show that benefit, you need to follow them up to 8 years, 10 years before you find. My thought on this is that first let's do moderate and be very good in it before we're not even doing moderate. Why think of mild? Not yet. I wouldn't cool mild. Having said that, most of the Western countries, even where I work now, there's what is called a therapeutic drift. So people are cooling, giving the benefit of the doubt and cooling babies with mild. I would say 30-40% of the babies who are cooled actually mild without enough evidence.
Anything, I think we should be confident with the more risky babies, and then we go for the milder cases. As he rightly put it, milder cases also may have some neurological problem may be there. So they may also be benefited, and I think many people believe that milder cases also may be cooled. But side effects or the adverse effects with the moderate and severe asphyxia, we should control first. We should get good experience, we should get. Then probably we can go for mild asphyxia babies.
Yeah. Since therapeutic hypothermia is now being considered as standard of care, and most of the units are, especially in India, now starting actually. So many even in tier 2 cities also. So now we should concentrate more on quality improvement, improving the nursing care, and making a follow protocol, monitoring aspects. So all these things we need to improve before going on to other aspects like milder cooling and milder encephalopathy cooling and all these things. Sir, thank you very much, sir, for your wonderful lecture. And sir, shall we hand over to the organizers?
Yeah. There are more than 60, 70 questions. I think you can email Dr. Niranjan for further enquiries, because we have to close. People may become restless after some time. Yeah, we will hand over to the organizers.
And in Melbourne, we have entered the next day now. It's past midnight.
But you are enthusiastic, you see.
Yeah, I'm passionate about this. So.
Yes. So we will go to the organizers now.
Thank you so much, Professor Niranjan, Professor Vishnu Bhatt, and Dr. Sunil. Before we move on to vote of thanks, there is a small announcement. We were supposed to have 3 webinars on neuroprotection in December. The second one was scheduled mid-month on updates and controversies in therapeutic hypothermia by Professor Sita Shankaran. But due to some technical reasons, we had to postpone that session. So we will have a different session. On 14th of December, we are going to have safety issues, the 5-prong approach by Professor Gautam Suresh. And then the third webinar on neuroprotection, which is scheduled, will go on as scheduled on 23rd on a very novel concept that is on using technology to protect brains in resource limited settings, something that has been proven by a team led by Dr. Gabriel from Brazil. So the same team will be presenting that on 23rd of December. So the next webinar will be on 14th on safety issues in NICU, including the medication errors and things like that, and how to tackle them, the 5-prong approach. Now, may I request my colleague, Dr. Manjusha, to kindly propose a vote of thanks. Thank you.
Thank you, sir. On behalf of Team IAP Neocon 2020-2021, I wholeheartedly thank our legend for today, Professor Dr. Niranjan Thomas, for being with us all this time despite the different time zones we are in. Sir has been so passionate about the topic that he had agreed to sit, as sir already mentions, almost the next day there. And we could never have got anyone much better than you to talk on this topic, sir. Thank you so much for joining us. And this session would not have been complete without the excellent moderation by our moderators, Professor Dr. Vishnu Bhatt sir and Dr. Sunil Kishore sir, who themselves are legends in the same topic and known all over India. And I thank all the participants on Zoom as well as on YouTube for their active participation, the expert for today. And we look forward to your participation in our upcoming session on 14th of December at 7:30 p.m. That's a Monday, on patient safety in an ICU, a 5-pronged approach by Professor K. Suresh Gautam from USA. Till then, it's thank from Team IAP Neocon 2020-2021. Thank you. Have a nice evening.
Thank you, one and all.
Thank you. Thank you very much.